everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to our Spine Talks presentation, where we bring you unparalleled access to world-class experts, like these doctors who are joining me on the panel today. Spine Talks brings you education so that you can get answers to your most pressing spine health questions. Our panel will be moderated today by Dr. Tom Schuler, Chairman of our Medical and Scientific Board.
Well, we're so excited to be here in Las Vegas. What we try to do with Spine Talks is to get the nation's best experts to help you understand what works, what doesn't work, how to take care of yourself, and how to get more information. Dom Coric is here, who is the head of the organization that is hosting this conference, so we're very excited to hear about that. We have Dr. Tumialan, who's here to help give us his insight and his leadership from the organization, as well as Dr. Ghogawala and Dr. Wang. So gentlemen, so we'll start with you, Dom. Can you tell us a little bit about what's being covered this week at your conference?
Sure. This conference is the colloquially known as the spine section. It stands for the ANSCNS, which is the American Association of Neurological Surgeons, and the Congress of Neurological Surgeons Joint Section on Disorders of Spine and Peripheral Nerves. So that's kind of a mouthful, so we go by Spine Section or Spine Summit. And we're here to discuss all things spine, basically, everything to do with spine, intraoperative, postoperative, preoperative, patient care, and to act as advocates for patients, as well as our membership, which are spine surgeons.
Well, there's so much that's happened in the world of spine, and we know that the entire concept of spinal treatment has changed. And we go from the dark ages and medieval treatments that prevailed in the 80s and 90s to the truly amazing technology that we have today and the knowledge and how to get it better. And I was talking to you, Dr. Wang, and we were talking about some of the advances and that there's some great treatments out there, and obviously not everything works, but I didn't know if you had any thoughts for the public on the state of spine and what works and how to assess.
Yeah, I mean, Tom, first of all, my hat's off to you and Rita for starting the National Spine Health Foundation. What a fantastic need there is for information for the lay public out there. Spine problems are so common that virtually everybody's going to be afflicted by some kind of spine problem in their life, right? And you guys are providing a medium by which people can get real information, not some kind of advertisement and whatnot. And I think you're bringing up an important point, which is that the diagnostic and the treatment elements of spine are so complicated. That's why we have experts like folks on this panel. And the evidence is building every day for new treatments or new diagnostic modalities. And I mean, Zoe, you've been leading a lot of that. You were in the Wall Street Journal twice, I think, talking about the studies you've led around the country, right?
Mm-hmm, mm-hmm. I mean, I think you're right, and also my hat's off to the organization here, both for providing information to patients that patients need, and in a forum that is understandable. What Dr. Wang is alluding to is we as spine surgeons get together, we organize ourselves, and we are as interested in getting the best outcomes for patients as every single patient would be. And part of our effort is to make certain that we organize ourselves together so that we collect our surgical information in national registries so that we can document which operations are working well in what type of patient, and we can customize solutions for patients. So it's really important. One of the things that Dr. Wang didn't mention, which I think is really, really important to patients, is that we've come a long way in spinal surgery, and a lot of people, and I think Dr. Wang is one of the international leaders in this regard, have moved the needle towards minimally invasive spinal surgery. And minimally invasive spine surgery is not for every type of spine problem, but when it is applicable for patients, it's a great solution and has less time in the hospital, lower complication rates, and faster recovery for patients. So I think that's something that's really important for us to focus on.
So Lou, let's talk about that. What is minimally invasive? What does that mean?
Minimally invasive surgery of the spine I believe, has always been our destiny. Since we started operating on the spine, no one ever said, well, I'm going to figure out a way to make this incision bigger to do the same operation. So since the dawn of the first operations to decompress the nerve roots, which actually started in the 1920s, is when the final connection was made that, oh, you're having pain down your leg. It's actually not caused by your hip or your sacroiliac joint. It's actually caused by a disc on a nerve root. It's hard to believe that in still some of our patients' lifetimes, that the operation to decompress something which is called a lumbar radiculopathy, pain down the leg, caused by a disc herniation. That's only 100 years old. When surgeons began seeing the consequences of what they were doing to the spine, to get to the other side, to decompress a nerve root, to take the pressure off the nerve and alleviate the pain, they said, there's got to be another way to do this. And our destiny since that operation first started has always been to see how we can do things smaller and smaller. So what minimally invasive spine surgery, the way I would interpret that, when a patient is trying to organize in their mind, what is minimally invasive surgery? It's getting the same operation that would otherwise be done through a much larger incision with greater exposure and disruption of the anatomy, getting the same operation done through a smaller exposure. Sometimes, like what Dr. Wang does, is using endoscopes or using minimal access ports and accomplishing the same operation that would otherwise take a much longer time, a longer recovery, and doing the same job through a smaller exposure.
So Dom, why do we care about minimally invasive? Why would a patient want that?
Well, like Lou was talking about, minimally invasive is not a certain size of an incision, it's a philosophy. And that philosophy is that you want to affect a change in the patient's pain by relieving the pressure on a nerve, but you want to do that in a fashion that disrupts the normal tissue as little as possible. So it's not to say that Lou does an incision that's 2 inches and I do a 3 inch, so he's minimally invasive. It's the concept of whatever he can do to decrease the pressure on and disruption of the normal tissues is going to be done to achieve that common goal of decompressing your nerves and getting your pain better.
Zoe?
Yeah, I can perhaps put this in real life terms, and I agree with everything that Dr. Coric just said. I remember a few years ago, my wife's father had a very bad spine condition. He could barely walk, and he was in his 80s, and he had seen a spinal surgeon in London who had basically said that because of his weak heart and some of his medical conditions, and mind you, he was in his mid-80s, that he just wasn't a candidate for spinal surgery to fix his problem. And he had a very common condition known as lumbar spinal stenosis, where he had arthritis in his lower back that had constricted the nerves that were going down to his legs, and he just couldn't walk. And so I called Dr. Wang and said, you know, is there something that can be done? And what happened for my wife's father was he went from being inoperable with an open spine surgery to going down to Miami to have a minimally invasive operation through a small scope. And the end result of that was that Dr. Wang's team was able to let him out of the hospital the next day. He used a lot of local anesthetics, so there was very little pain for him. And he was walking on Miami Beach within 3 days of having his operation with absolutely normal heart function. And to me, you know, as I look at that, you know, one as a surgeon, but also as a family member, you know, the opportunity to get an operation done and have, you know, minimal time in the hospital, be up on your feet, walking quickly, is just remarkable. And I think it just says so much about where spine surgery has gone in the last 10 years or so.
Mike, you want to comment?
I mean, Zoe's being too kind. I think people come to Miami Beach because it's warm in the winter, and right now it's 80 degrees. No, I mean, this panel of experts, Tom, that you've assembled, you know, and Rita as well, she's a physician, right? The amazing thing about coming to these meetings, and all of us have a role in this particular society, is that we get to see the technology, the advancements. And I look around and I see, you know, Dom obviously as a leader of new technology, Lou, who's been very much involved in Washington as an advocate for patients so people can get access to the treatments they need. Zoe as a leader in science, you know, creating evidence for why we need to do this or that. But to me, I'm kind of a tinker, and I really think that, you know, people are looking for the newer ways of doing things. The newer is not always better, but the new options provide the opportunity to make something very scary, right? Spine surgery is, for whatever reason, considered very scary for people in America. It really doesn't need to be always so scary. And the technologies, whether it be like robotics or some cellular materials that can help bone grow, or the devices that allow us to do minimally invasive surgery, these are all integral. And actually, Dom Coric's group at Carolina Neurosurgical Associates, right?
Carolina Neurosurgery and Spine Associates.
Yeah, you guys, I mean, you guys have more, and you, Lou, at the BNI, and Zoher Clinic and here in Miami, for me, one of the things we've been blessed with is to be here at a time when there's a renaissance of technology. And then building the evidence and the advocacy and, and the education for that, for the betterment of our patients.
Well, Mike, I think that you touch on this idea of patients being so afraid of back surgery, and yet it's generally accepted that if you need a hip replacement, you get a hip replacement. If you need a knee replacement, you get a knee replacement. But back surgery, I don't know if I don't want to have back surgery. And so I think there's a real opportunity for patients and for the public to understand how far you've come as a field, and your expertise in sharing that and educating people coming out of the dark ages into a renaissance of treatment to get people in their 80s even back on their feet. That's.
But Rita, I think this is where you're doing a great service, because the NSHF, I mean, what you can provide is this megaphone so people can start to understand, and I can imagine this being a teaser for a lot of future episodes to talk about why is it that people are so afraid. And you're looking at a panel of folks who are actually very conservative surgeons, everybody here, right? And we're picky and we have really good outcomes, but why is it that people are so scared, right?
Well, and if I could tag on to that, Mike, I think you make a great point, because there is a dichotomy, and that dichotomy is that spine surgery is a big deal, and it should be a big deal to the patients. And the other point that I'll pick up on that you laid down was the idea we operate on an incredibly small percentage of the patients that we see. Ruptured disc, everyone says, oh, you got a ruptured disc, you have to have surgery. Probably 60-70% of people with ruptured disc don't ever have any kind of surgery. If you look at the amount of patient encounters we have at our group, we have upwards about 35,000 patient encounters, and we do about 4,000 or 5,000 surgeries, and that's for people who are actually seeing surgeons, have gotten through that crucible. And so the reality is that we're operating on 5, 10, 15% of people who need it. And again, the people who need it like Zoe's family member, Zoe's father-in-law, his nerves are being pinched. Spinal stenosis, it sounds like it's an intimidating term. Your spinal canal is a tube, and in that tube you have spinal fluid and you have nerves. Anything that narrows that tube is called stenosis. It's just a generic name for narrowing. And when that stenosis gets to a critical point, there's just no more room for the nerves. And you can't treat that. We all advocate physical therapy. We all advocate non-surgical management. Everyone should have non-steroidal anti-inflammatories, physical therapy, consideration for certain injections. Surgery should be the last recourse, but when it gets to the point that there's no room for those nerves anymore, there's only one way to make more room, and that's to make more room, and that is surgical. Having said that, what Lou was saying, what Mike and Zoe are experts in, is doing that in as minimally invasive a way as possible to allow the patient to become as functional as possible. We don't operate to make pain go away. We operate to make people more functional.
Well, Dom, and I think that's where what Dr. Ghogawala has been doing at Lay Clinic has been really important. The kind of evidence, maybe you should talk about it, because I don't know that patients really understand. Like they ask for a doctor's opinion, but that's just an opinion. You're generating a science, a body of science, right?
Yeah, I think one of the ways to think about this is that traditionally, the way that doctors, surgeons included, have looked at the results of what we do is to look at our x-rays and look at our MRIs and say, as Dom just said, we decompress the nerves. One of the things that we have started to understand as we collect our evidence is that really ultimately what matters is what the results are for patients. When do they return to work? When do they stop needing to take pain medicine? When are they able to walk on Miami Beach for a mile without stopping? These are the things that are really fundamentally important to patients. And one of the nice things about this Spine Summit that Dom leads here is that it's the largest organization of spine surgeons in the United States that get together and we discuss how to get patients better, how to measure how patients are getting better, and we do it with a patient-centered approach. And I think that's really an advance, because ultimately we need to understand how these operations impact patients' lives and their families' lives. and to document that and then design our approaches as we transform technology so that we get those results to be better for patients. And I think we're getting much better at that than we ever have been in the past. And part of the reason for that is that we've really considered the outcome of the operation from a patient's perspective.
Well, this is exciting. I'd like to say that, I'm a spinal surgeon, have been doing this for over 30 years, and yet I'm a consumer too, because I've got fusions in my neck, disc replacements in my neck, laminectomies in my low back where we decompress those nerves that are pinched. And I know Dr. Roy has been a benefactor of spine surgery. She had spondylolisthesis, the slippage of the spine, and had to have it stabilized and the nerves decompressed. So as consumers, I think it's important for the public to understand that this is something which is life improving, life changing, and that's what we're so excited about. Obviously, we need to pick the right treatment for the right person, and everybody doesn't qualify for everything. So Lou, if you want to talk a little bit about how we would select what treatments to give people or why people may be a candidate for a specific treatment or something.
Yeah, I do want to touch on one thing that Dom said, because I think the point that you made, Dom, is very important. People come for us for an evaluation, and then when you tell them, like, look, you're going to be okay, they go, oh my God, I thought I was going to have surgery. I said, no. They seem genuinely surprised, and they're like, well, I thought you were a spine surgeon. I go, I'm a physician who treats people with spinal conditions. At times that involves surgery, and I do that. The other time, I have to explain to you why you're having what you're having. I have to explain to you what's going on, and we recommend, as Dom said, a course of physical therapy, achieving your ideal body mass index, and perhaps some epidural injections or other forms of non-operative measures. Then you see them back, and they're ready to go back in life. So it doesn't. What we do as spine, we are physicians that take care of conditions of the spine. At times it involves spine surgery. The vast majority of the time, it involves giving them guidance. Now, part of that guidance does involve selecting the operation, and that's where I can tell you, when I finished my residency, we think about the dark ages. The dark ages may have been 2008 for me, because the clinical decision-making that I have made, I've been fortunate to have Zoe as a mentor and as a friend, and involved with some of the studies that he does. And the expert panel that Zoe has assembled in this concept of having multiple individuals weigh in on what you're looking at, and how that iterative process of seeing how some of my colleagues would handle things has made my patient selection. For example, not everyone with spondylolisthesis, like what Rita has had, requires a lumbar fusion. Sometimes there's a lot of data that supports that they may just need a minimally invasive decompression, where it's a motion-preserving, minimally invasive intervention that allows them to get back to life, to a higher level of function. Other times, based on the data that Zoe has been able to assemble with his team, we make a decision saying, look, well, I don't really want that procedure. I go, the data would suggest that you're in a category that is going to have a very hard time long term. When I'm looking at a patient, I go, look, I want to give you an operation, offer you an intervention that's going to have staying power, perhaps the only intervention you'll need for the rest of your life. But if we look at this and we ignore the data and we just go by what it is that you want, as opposed to what the science would suggest based on all of your radiographic imaging, we can't get there from here.
One thing to add to what Lou just mentioned is that I think for patients, one of the things that probably a lot of patients do and is important is to get a second opinion. And what Lou's talking about is that we as a group of spine professionals are really focused on spine health. We do spinal surgery, we measure the outcomes from that surgery, but ultimately when we see a patient with a problem in their spine, we want to basically work towards getting them back to health. And sometimes that requires surgery, many times it does not. What we do with these expert panels, and all four of us are on these expert panels, is we take more complicated cases that involve the lower spine primarily, and we have a group of experts look at that case, look at the radiographic data, look at the other clinical aspects that you sit down with your doctor to review, And because of the technology that we have available to us, where the information can be transmitted electronically, essentially to someone's personal phone, we can get experts to look at individual cases very rapidly and then provide a comprehensive assessment for patients of how 10 or 15 doctors looked at your case. One of the things that we're presenting here at the Spine Summit is that when 80% of doctors agree that your case is best suited for, say, a spinal fusion, or on the other hand, your case might be best suited for a decompression, the outcomes from a patient perspective are better, which suggests that there's real value in getting second opinions or multiple opinions so that multiple people can look at your case.
And so just for the audience, this panel is not like random doctors from
Right.
like little tick towns. These are nothing wrong with them either, but like these are major academic centers of excellence, right?
Yes,
Fine.
yes, and that's been really important to us that, when we assemble groups of experts to look at these cases, as Mike says, these are people who are, nationally or internationally known. And by the way, we should mention that these expert panels include spinal surgeons from many places in the world that do excellent spinal surgery. So we get an international type of review for patients. And these doctors have documented excellent outcomes, as well as are doctors that have contributed to new information in the field in the form of publications.
But just to take it back to like the average person in America who's suffering at home, Googling stuff, the thing that I tell my patients, and I don't want to go too much off the rails here, but first of all, if you are looking for a spine doctor, spine surgeon, and you're looking for the number of stars, that is maybe the worst measure of who you're going for, because I'll tell you, I don't know any spine surgeon I respect that's 5 stars. It's impossible. If you see 5 stars, to me, that's paid for. I'm a solid 3.3, I think. But I think, the public, they think that that's the way to go. They go with whatever the media steers them to.
Yeah.
And what we're talking about is something very different here.
I think it's really true. We live in a world of ratings, right? Everything that we do is rated, whether it's a restaurant that we go to or a hotel that we go to and whatnot. But spinal surgery is not a hotel, and it's not a restaurant. And I think we need to rely on the spine section and professional societies to help us determine which doctors are providing the best outcomes, because ultimately that's the rating that you really want to have.
Some of the ratings goes down because you read them, or at least my mother goes, "You got another bad review?" So, but the rating goes down because you tell someone you don't need an operation,
Yeah.
right? And then they'll say, "He didn't believe I have pain."
Yeah.
And then because a patient in pain is vulnerable,
Yeah.
and they can be guided down a path that is not the right path. And then sometimes when you tell someone you don't need an operation, this is the course of action we're going to take, you can tell their body language is, oh boy, and then they say, he doesn't believe me.
At the end of the day, it is a vulnerable patient population, and it's a huge population because we already talked about how common back pain is. In fact, the second most common reason that people go to the doctor, and typically the first most common reason that people miss work. So it's incredibly common, number one. Number two, it should be reserved for, and we can really dumb this down and say there should be 2 basic reasons you have an operation. One is that your nerve or your spinal cord is endangered, or 2, your quality of life is absolutely intolerable, like your father-in-law was. Mm-hmm. Those are really the only 2 reasons you should be talking about doing spine surgery. And the problem is that people have a lot of pain, and there are a lot of snake oil salesmen out there, and the internet has put those snake oil salesmen in front of everybody. And so that's why I think what you guys are doing is so important with the foundation, because you need to get through all that noise, and you need to get to the bottom line of what my options are. And it's normal to be intimidated by it. Even we've thrown around spondylolisthesis, and you say, well, geez, that's a fancy word. Spondylolisthesis, spondy means body, listhesis means slippage. It's a slippage of one body on the other. There's nothing fancy about it. But the point is that people come in, and like Lou was talking about, and they're sometimes looking for a quick answer. And surgery is not for a quick answer. Surgery is to either make your quality of life that has become intolerable tolerable, Ken, or to protect your nerves or your spinal cord. That's it.
Lou also made another important point that gets back to something we had started talking about a few minutes ago, which is that, people say, or people hear, okay, I need a hip replacement, and there's not as much fear around that. Whereas in spinal surgery, sometimes there's a lot of concern. One of the problems I think that we have in spinal surgery is that, as Lou mentioned, patients are in really substantial agony when they have a serious spinal problem. And not all spinal problems can be fixed with surgery. However, when you have a desperate patient and a well-intentioned doctor who just wants to help, sometimes an operation gets done that doesn't work. And that operation that doesn't work, I think, has given spinal surgery a bad name in the general public's eyes. One of the things that I think we have done in spinal surgery to help ourselves is to document the outcomes from a patient perspective so that we can really reduce the number of operations that are being recommended to patients that are just not likely to work for whatever reason.
But the opposite is also true, right? So I think this is one of the funny things about spine care is that we have competitors, right? So I know there are lots of surgeons out there that and there should be none, that do too much surgery that's unindicated. But I also know that that's even more so the case with the non-surgical spine providers. And I'm not indicting them because it's lower risk to do the other things. But we should be really hard on ourselves. And there have been some really bad actors in the spine world that have been disciplined, and it's become very public. But it happens in all the other worlds too, whether it be pain management, whether it be physical therapists, whether it be chiropractors, and now you have anesthesiologists trying to do surgery, right? Everywhere you turn, they're doing surgical procedures that they're not supposed to do. Now, you can argue that the areas being blurred between surgery and not, but I just don't want everybody listening to think that, well, spine surgery is just something that is purely reserved, but everything else is totally game.
Minimally invasive surgery at some level becomes a catchword. And so people say, I'm going to have it minimally invasive. To what Lou talked about earlier, you want minimally invasive means doing the same operation, accomplishing the same goals of decompressing the nerves and the spinal cord and stabilizing the spine, but doing it in a tissue-sparing way. It's not to say that it's, you get on the internet and it's, minimally invasive this, or you can cure that without surgery. There's a lot of snake oil out there, and there's no question.
So Dom, what advice do you give people? Like someone's sitting at home, they're listening to us, right? How do you go about as a patient looking for the right level of care? Because I assume patients don't know. Like, should I have a shot? Should I have therapy? Should I have surgery? How do you guys counsel folks on what to do? Tom, what do you do?
It's important for them to understand what their problem is. When we talk about it, their pathology. Do they have a herniated disc, a degenerative disc? Do they have a facet joint that's arthritic? Is there a nerve that's pinched? There are all these words that we're throwing out here are structures in the spine. And it's how do we reach inside that black box of the spine, identify the problem, and then say, what is the best solution to this? And that solution may be non-operative. It may be, let's work on mobilizing tissues, strengthening muscles, trying an injection of some kind to see if we can treat it, or ultimately we say, this problem will not improve until we fix it. So the disc herniation we talked about, I always equate with a garden hose that's kinked. If your garden hose is kinked, until you unkink it, the water doesn't flow. And what we do at the time of surgery is we unkink the garden hose, give the nerve some relief, and let the nerve function properly. And so it depends on what the pathology is in terms of what we recommend, but it's educating the patient about what their problem is and then what the options are.
The good news, and on the flip side of what Mike was saying, is that when there is a surgical target, good news. And because, like Dom said, the majority of the time we're saying you don't have a surgical target. And I think that's what you're trying to establish: surgical target, no surgical target. When they have a surgical target, then we have a reliable way to get them to the other side and turn the page on this It's a huge disruption in their lives, right? They come in, they look like they haven't slept, their marriage is falling apart, perhaps they're drinking too much alcohol, they're taking too much. You start listening to, whoa, your life is, and I go, why are you going through this? You've had all of these procedures done, and you have, it's the proverbial thorn in the lion's foot. One little clump of disc right on that nerve root, and they've been suffering for this since Thanksgiving. And the patient I saw before I came out here, I go, why are you doing this to yourself? Well, I don't want to have spine surgery.
One of the things that I think is really practical for patients, and Mike asked Dom this, but what I would suggest for patients is to look for a comprehensive spine type center where you've got multiple doctors that are working together. And I think that often helps because a collaborative approach to spine care allows the doctor who focuses on doing injections to be working very closely with a surgeon who does operations, who's also working very closely with a physiatrist that does physical therapy. And you have all of these people working together for you, as opposed to going to a place where there's just one type of approach, either a physical therapy approach or an injection approach, or just purely a surgical approach. I think for patients, the comprehensive spine approach is probably the most valuable, and it allows doctors to work better together to get a solution for patients. And one of the things that I sometimes hear from patients is that they've been seeing a group of doctors that say only does injections, and they've been getting injections for a nerve problem for, say, 10 years. And they then ultimately have an operation to get that fixed, and they're just amazed that the last 10 years they were just going in and out, getting multiple little Band-Aid type of approaches that weren't ultimately solving the problem.
Yeah, I mean, I think your point, Zoe, when all you have is a hammer, everything starts looking like a nail.
Exactly.
And this comprehensive approach really is the way it should. You should work in concert with pain management, with interventionalists, with other folks. But when in isolation, that's when you get into a problem. The other thing I think that's unique about spine pain, nerve pain, and you know it, Tom, and you know it, Rita, as well, people don't understand what you're going through unless they've had it done before. In other words, most everyone's broken a bone or stubbed a toe, and that hurts, but nerve pain is nothing like that kind of pain. Nerve pain is nauseating. It allows you to not sleep. It makes you depressed. There are problems that go beyond, true nerve pain is something that really needs to be taken care of. And pain is typically your body's warning sign that something else could be coming. In other words, there are worse things than pain, and that's typically weakness or loss of function in the distribution of the nerve or the spinal cord. These are things that have serious ramifications.
A lot of times people say, well, spine, we're not saving lives. But I would argue you are saving lives. Because if you are a person who has suffered with a spinal condition, you do feel like your life has ended. And the life that you've known is ended. And to be told you're never going to ski again, you're never going to, get on the ground and play with your grandchildren again, it feels like your life has ended. So, I think of these procedures and opportunities to regain life as not just improving quality of life, but really saving life. It really is saving people's lives. And we don't think about this. We think about spine surgery as being elective. Well, nobody decides that they want to just have a spine surgery. These are life-saving, life-preserving, and quality of life procedures, whether it's an operation or an injection, whatever the treatment modality is. But to your point, if you've had debilitating spine pain, you feel like your life is over.
So Rita, to that point, I did my studies in neurosurgery in Boston at the Mass General Hospital, where the hospital was originally a mental asylum. And I was interested in reading some of the stories, and there's a story that your comments bring to mind, and that is that there was a patient that was placed in a mental asylum in Boston around the early 1900s, who was complaining of a fiery shooting pain down her leg. And she was described by the nurses as, banging on walls and screaming and curled up in a ball in the corner. She ultimately died. And when they did an autopsy, she had a herniated disc. And it just wasn't known at that time what that was, but she was basically being called insane because of the level of pain that she was going through. And I think that's an important point, and Dom mentioned it, that the level of pain that people go through who have spinal problems is an order of magnitude higher than many others.
We are trained in neurosurgery to do something called the Lasag sign, right? The straight leg raise. And Lasag was actually a psychiatrist.
Oh my goodness.
He was a psychiatrist. He was not a neurologist. He was not a neurosurgeon. Well, there was no neurosurgeons because you're talking 1860s in France. And what he used that sign to determine whether someone had a true psychiatric problem or had a genuine radiculopathy.
Talk about mind-body all the time, and when you've got a debilitating spinal condition, you're not moving. And when you're not moving, there's all kinds of mental and mindful, consequences to that.
Talking about the evolution of healthcare, you're talking 1860, a psychiatrist is coming up with this exam finding, and it wasn't until 1934 that the disc herniation was diagnosed, and we understood that was something that could create a problem. And you think of the time in the evolution, and here we are in 2022, and the techniques we have, the knowledge we have, dwarfs everything we had before. And we know that in another 30 years, they're going to be looking back saying, God, those guys didn't know very much. but it's a process of learning. So I'd just like to close with getting some words of advice, some pearls of wisdom to help our patients that are listening and learning. So Mike, why don't you tee it off? Do you have a word of advice?
I would like to see something that you're doing at the National Spine Health Foundation come to fruition, which is a problem I've had at University of Miami. The number of patients who need a good opinion, it's millions of people a year, right? And I know the Cleveland Clinic and the Mayo Clinic have a system where people can pay to send their MRI in and people are reviewing their data, but it's hard to get a good opinion. And I find that in my clinic, really what happens is the people who are able to get access, and I consider myself ethical, I don't know if other people would think that, I really try hard to do the ethical thing. And when they come to me, they always had some avenue in, but that means that I've lost the opportunity to help so many other people. I've treated almost all my neighbors. I see almost upwards of 100 people a week in clinic. That's a lot of patients to see, right? So hence, not every review is going to be perfect, right? I've got to see a lot of people to do the right thing for them. And I would love to see a system, a clearinghouse, whereby humans, American citizens, can get ethical care, whether it's, as we've been talking about for some time now, do you need a surgery? What kind of surgery is Dr. Ghogawala figuring out for us? Is it non-surgical? And give some authority to it besides having to go to an academic medical center. And I think that's what this country really needs.
Getting information, and I think that's what you're doing for patients, is really, really necessary and important. And I would say for patients, when you're sitting down and talking to an expert and you have a spine problem, there are a couple of things that I think are really important to get answers to. One is if in the case of spinal surgery, you're having an operation, what is the data around your recovery? When will you get back to work? When will you be able to get back to playing tennis? When will you be able to get back out on the golf course? And I think you should really push your doctor to provide that information to you. And quite honestly, if you have a physician that doesn't have that kind of information, that might be time to be looking for a different professional. The other thing I think that is really important for patients is to be able to have an honest conversation with their doctor, their surgeon, about complications. There can be complications from non-surgical type strategies. There can be complications from physical therapy. But there can be complications from surgery. And having an honest discussion about what those kinds of things are, what they could mean. A lot of complications that can occur from surgery, for example, resolve very quickly and are not necessarily reasons not to proceed with having an operation, but you've got to have that honest conversation about what this is all about, what it could mean for you, before you then are able to make decisions. And then one last point I would just add is that, we try to do this with our expert panels, but getting more than one opinion about your condition, I think, is just beneficial in terms of getting a better understanding of what's going on.
If I could say one thing to our audience, why wait until you have a problem? Why we go to the doctor, get our blood drawn every year. If your cholesterol's high, you start taking medications. If you have high blood pressure, take that. But in the meantime, in the third and fourth decade of life, all of our spines begin degenerating. We all begin to lose muscle mass. Personal story for me, at age 40, I threw out my back. Why? I was deconditioned. I was a dad. The 3 cheeses, mac and cheese was waiting there. The kids didn't eat it. I ate that. Then my wife goes, here's your dinner. And then next thing you know, I've put on weight. I've deconditioned. I always envisioned myself as healthy and fit, and I wasn't. And I injured my back right before my 40th birthday, so much so that my wife had to cancel the entire birthday party. All the friends that were flying in, she canceled it because I was bedridden.
Wow.
This is all a true story.
Wow.
And I used to poo-poo physical therapy. I used to kind of like, well, I guess you can try physical therapy. The reality is I lost weight, I got my core strong, and I got better. Why wait? Why wait? Because then it's going to be the same story. I picked up a case of water at Costco. Boom. It's going to be that home improvement project because your spine is not used to anything. Your muscles are deconditioned, and next thing you know, you're building a garden in the backyard or you're doing a home improvement project, and then the whole world unravels. It is preventative medicine that we don't communicate. If I could tell anyone out there listening, don't wait for the back problem to start. Preventive medicine. I can lose another 5. We could all lose a little weight. I need to get my core stronger, and we all need to keep ourselves a little bit in better shape. We do that. If you ask me, that's what America needs.
Spine surgery is a big deal. Someone is in there manipulating your nerves, your spinal cord. The complications can be atrocious. So when you have a problem like that, what is the first thing that you should do? First thing that I would do is find the smartest person I know to talk about, and that includes guys on this board. But the point is that look at the training of somebody to become an orthopedic or a neurosurgical spine surgeon. For a neurosurgeon to become a spine surgeon, you have to go through 4 years of medical school, you have to go through a residency of 7 years, and then usually a 1 or 2 year fellowship. So compare the credentials of someone like that to somebody who is on the internet saying that, I've got the cure for back surgery. Well, if that guy had the cure for back surgery, he will have won a Nobel Prize. He wouldn't be on the internet looking to sell you his latest, greatest thing. Talk to smart people. Talk to people who are credentialed, people who have done things in the field. And if you've got a bad problem, talk to the smartest person you know. And to Zoe's point, talk to a couple of them. I know for a fact that everyone on this panel and any legitimate practitioner is not afraid for people to get second opinions because they're confident in what you're telling the patient. So go ahead and talk to somebody else. Educate yourself, but don't educate yourself to the point that you're going to try to run your own care. Find a smart person and an experienced person and listen to what they have to say.
Spine health is a lifetime commitment, and it only happens if you invest in it. And like Lou said, we have to exercise, we have to do fitness. Exercise is medicine. And at the end of the day, if we don't take care of our responsibility of maintaining appropriate body weight, doing our exercise, working on our flexibility, it's hard for us to walk in to talk to a practitioner and expect them to help. And so we have to understand that we all have our own responsibility, and life's tough. We all have obligations, family, jobs, things that get in the way and affect it. We need to be constantly working at this, and if we fall off the wagon, we got to climb back on the next day and keep at it. It's a lifetime commitment. Motion is good. We want to preserve motion. We want people functioning, and so that's important. And I just am so excited about this panel. You guys have been great. It's been easy. I didn't have to do any of the interviewing. They all interviewed each other, so it made it very easy for me.
So blessed to be able to hear directly from the world's leading experts. And we hope that this education gives hope to people who are suffering.